with the ratio of good effects to bad effects. And what they have that I haven't seen anywhere else is that if drug X does not work, what's the best thing to think about for drug Y or drug Z? Because the drug companies don't do that. They just say, does it work or not? And we as clinicians need to know the next set of questions.
So today on the podcast, I have Dr. Robert Post. He is an MD with a long and illustrious career working in the field of psychiatry. So, Dr. Post, I'm excited to have you on today and talk about some of the current and historical issues in the field of psychiatry.
Somebody get this guy some help!
The other thing is when you talk about 150 milligrams of lithium, there's actually data in adults. In adults with mild cognitive impairment, if they take 150 milligrams of lithium for 1 year compared to placebo, they have less cognitive decline. So even low dose lithium, it seems like it's doing some positive things in brain. And it's a tough set of issues. And we need to be thinking about the assets of lithium a lot more than its side effects.
Can you recall where that study or that information is, and if they use something like the clinical dementia rating scale?
Yeah, it's a study from Brazil, and they did it with clinical ratings, and they even had some brain imaging studies that the brains look better on lithium than without. The references is in that slideshow that I sent. And anybody who wants any of the slides on these issues that we're talking about, they can email me at robert.postmd@gmail.com, or they can get the slides from you too. I send you a packet. So the references to those things are actually in there.
That's very, very gracious of you. So if you developed dementia, what would you prefer to take as your treatment?
Yeah, it all depends on the stage. If I were having mild cognitive impairment, I would want to head it off and see if I could keep it at mild with a little bit of lithium. If it were more major, then I would want to go with some of the other more reasonable treatments. One of them is memantine. And Namenda is actually also underutilized for bipolar disorder, that a guy named Koukopoulos from Italy added Namenda to very rapid cycling bipolar adults, and he got a remarkably high incidence of remission. So Namenda, quite aside from its pro-cognitive effect in dementia, it could have an anti-cycling effect and also has some positive effects on ADHD and executive functioning. So if somebody doesn't have a good enough response to lamotrigine, for example, which decreases glutamate release, you can augment that antidepressant response to lamotrigine with memantine, which blocks the glutamate receptor, the NMDA receptor. So you got a double action in cooling off a hyperactive glutamate system. And Namenda is a good drug. So I would use the combination of the cholinesterase inhibitor and memantine first, because there's data that if you treat with that combination, you get better data than either drug alone. And I'm not well enough informed about the new Alzheimer's drug. So I would, if I got dementia, I'd want both of those drugs in combination.
The newer Alzheimer's drugs are, I got really fired up. I get fired up about my patients if I think somebody is really mismanaging them. And I've got a younger end Alzheimer's patient who pretty significant memory loss, but other than that, lives independently and makes it to all her appointments. And we've been using a very low dose of lithium, not just for her psychiatric condition, but also to stave off any progression of that. And she came to an appointment the other day and couldn't remember why or how, but she had been evaluated for dementia, and she was being initiated on that protocol for those lecanemab, Leqembi, the new class of drugs. And I really don't think that that class of drugs has any sort of proven efficacy to the degree where it warrants its use based on the risks associated with it. And I looked up, and sure enough, the EMA gave one of its 4 negative opinions on drugs for the year out of about 130 on lecanemab just in the last couple of months. So the makers filed for a reexamination of that. You know, we have these treatments that are tried and true and proven, and they're not curative, but to me, that, you know, what I do is all about evaluating benefit versus risk and trying to make complex decisions based on that.
Yeah, well, you're way ahead of me on the new anti-Alzheimer's drugs and their risks and benefits. I only know about some of the older ones. Yeah, so it would be nice if some of the Alzheimer's drugs turned out to be really good, but I agree with you, the data aren't there yet.
Well, it was a huge red flag back in, I think it was January of 2021, when aducanumab got the accelerated approval. And I think it was 9 members of the FDA Scientific Advisory Board. There was only one that agreed with that decision to conditionally approve it. And then actually 3 people resigned from that board based on that approval. So, and I think that was kind of a shifting of the tide of that FDA approval process, and it getting less and less stringent in what we allow our patients to take. So I always go back to what my mother, who was a pharmacist, taught me at a young age. You don't know the effects of a medication or a class of medications until it's been out for 15 or 20 years.
Yeah, exactly. Exactly. And lithium's been around for almost 50 years, and we're underestimating its utility and overestimating its side effects. And we know exactly how that one goes.
Yeah, absolutely. So you were at the NIMH for many, many years. I was reading one of the excerpts in a response by Markowitz and Milrod on your paper titled Stigma Kills Psychiatric Patients and is Now Killing Clinical Research Too, where there's significant criticism of the National Institutes of Mental Health putting more than 90% of its funding towards neuroscience and research domain criteria. Can you expand on this criticism? Tell us more in your view about how the NIMH has changed over time from when you started working there to now, and maybe what changes need to be made to help our field actually advance in our scientific understanding and treatment of mental illness?
Yeah, it's a tough one because NIMH has actually stopped funding clinical trials in either adults or kids, and they're looking for these exotic gene-related newfangled treatments. And my view is that we got a ton of treatments out there, and we don't know how to use these drugs well enough. We don't know how to treat young kids, for example. The clinical trials in young kids are, essentially non-existent. It's actually criminal. It's a horrible thing. And I think some of it is related to the stigma of psychiatry in general and to the notion that if you're a clinician like you and you're very interested in this risk-benefit ratio, that they don't take that seriously enough. They think you got to be a molecular biologist or a neurobiologist or some other thing like that in order to be a good doc, and that's complete baloney.
Yeah, I am not a neurobiologist, but I feel like I have a pretty good sense of understanding that there are a lot of external motivations that go into the production of a new drug or the approval of a new drug. And, I try to embrace uncertainty, but it can be really difficult to parse these things out. And especially as a young clinician, who received training that didn't include any initiation of something like an MAOI, that did not include a lot of use of lithium, had to go outside of the bounds of my training to learn more about those things. It can be difficult to learn those things and then put those things into practice. I kind of worry that the next generation of psychiatrists won't be that much more prepared than the primary care doctor that is treating a lot of mental health patients.
Yeah, I'm afraid you're correct on that one. We need to switch this ratio more into clinicians and MDs who are interested in treating patients carefully and well, and do the clinical trials that give them the information that allows them to treat them best. Because, all these questions that we have about how to treat these early onset kids, none of them are answered. There are no studies out there about kids with bipolar not otherwise specified, or all over the place. And everybody agrees that these kids are very disturbed. They're almost as disturbed as bipolar 1, bipolar 2, but there's no studies on them. And that's actually a tragedy. It's a serious problem, and hopefully the new people heading up the NIH will actually change that, because the NIMH says that one of the things that they're interested in is treating illnesses earlier and heading off illness progression, but they don't do any studies of it. The other thing is, if they find some new drug, they're still going to need to know how to use it, when to use it, and what its long-term effects are. So the idea of cutting off clinical treatment studies at the NIMH is sort of ludicrous. The drug companies do it because they need the FDA approval, but we really need comparative clinical trials. Which drug is better than which other drug, and what to do next if the first drug doesn't work. And right now, those data aren't out there.
Do you think that the increasing proportion of funding that the NIH gets coming from pharmaceutical companies is a problem over the last 20 years?
No, no, it's sort of the opposite. The drug companies used to give good CME lectures that I love to go to at the APA and all that kind of stuff. And they screwed that up too. They ended that kind of fundings. I don't think it's the drug company's fault. I think it's the other way around. I think the drug companies are afraid to study kids, actually, because they'll get criticized as trying to create a new illness or some other baloney like that. So I don't think it's pharmaceutical problem. I think it's the other way around. I think it's the NIMH hierarchy that somehow thinks that newfangled things are better than the old ones, even though we don't know how the old ones are working and how to put them together in the best possible way.
Well, I'll tell you, the beta amyloid removing drugs, you could treat, let me do the math real quick. When they came out, they were roughly $56,000 a year for the time of the infusions. And you could treat essentially about 5,000 patients with a low dose of lithium versus one patient with aducanumab. So I think there's certainly a motivating factor of finances, but the drug companies, their job is to create drugs and to promote their drugs. And we live in a country where they are allowed and it is legal for them to advertise their drugs. So to me, it kind of falls back on the regulatory bodies not doing their job effectively, not having this independent force that evaluates clinical trials, that looks at some of the ways these things are designed, or that forces companies to put all of their data out there for people like you and me to review.
Yeah, so exactly. There's data out there that risperidone is a very good anti-manic drug. However, has lots of side effects. It makes people overweight. We have a lot of other anti-manic and antidepressant atypicals that don't cause that degree of side effects or weight gain. Like Latuda is FDA approved for kids 10 to 17. It's weight neutral, has very few side effects. There's no comparative data on those drugs. And now we have other ones like luteperone and Capletta and cariprazine, those kinds of drugs that have antidepressant effects built into them as atypicals along with Latuda. We don't have any comparative clinical trials. That's what the NIMH is supposed to be telling us and doing. So that's not a drug company problem. The drug companies, are just trying to get their drugs out there. They've got good drugs out there, and now we need to know their comparative efficacy and side effects profile so that we get the best drugs in our patients the earliest and head off this illness in the long term.
And to be able to reproduce those results with a different set of scientists, researchers in a, similar but separate patient population to really lend more credence to the theory, right? Because everything in science is a theory. There are very few things that are really proven, but we develop stronger and stronger theories as we move along. And I just feel like we've really lost that independence or the independent evaluating body, or even allowing scientists and researchers to be the ones that dictate what is effective and what is not effective.
Yeah, I'll take the data on efficacy and tolerability over any kind of theory any day. If it works for a patient and it works long term, that's the name of the game. So, yeah, replicating that and comparing data on what works in the short term, what works in the long term, and what's most tolerable. That's the other thing, is I think we need to use tolerability as a big deal in our choice of meds and not give patients medicines that have a huge overburden of making them overweight. We now have a lot of relatively weight neutral drugs that we can use more of. So the tolerability issue needs to be factored in there big time. The Canadians have the olanzapine fluoxetine combination drug in there as highly effective for mania, but they have it much lower in their usage because of the side effects profile and its weight gain liability. So tolerability, efficacy, obviously, but then tolerability is a key point.
I had Jose Rubio on a few weeks ago, who is one of John Kane's proteges, and he was promoting that Clozaril is very underutilized in psychiatry, but he's working on developing this predictive score, which I think would be so useful for every medication in specific populations, that allows us to give a number that measures both the benefits and the risks of a certain treatment, so that you have a much stronger factor put into the risk of suicide than you do to the risk of the drug giving you a mild headache, right?
Yeah, absolutely, for sure. That would be a wonderful thing to have.
It's a lot of math, though.
Yeah, but it may be a lot of math and require some huge numbers, but it's something that clinicians can do in their head in a relatively easy way. And if they know that this drug has a lot of side effects and this drug doesn't, boom. The other thing is, if you really want to know that ratio of efficacy to side effects, look at the Canadian guidelines for treatment of bipolar illness. Lashmi Latham has put that together with a whole group of experts, and they really have that very well laid out with the ratio of good effects to bad effects. And what they have that I haven't seen anywhere else is that if drug X does not work, what's the best thing to think about for drug Y or drug Z? Because the drug companies don't do that. They just say, does it work or not? And we as clinicians need to know the next set of questions. How well does it work? Is it going to get our patients all better? And then if it doesn't, what do we do next? And that's where the NIMH has fallen flat on its face. If my wife tells me not to swear when I'm giving talks, but that's worth some swear words about
Go ahead. We do allow swearing here on Renegade Psych, hence the name.
Yeah, well, my wife tells me don't do it, so I got to listen to her.
That's fair. That's fair. No, that sounds like it would be a very useful tool or way to study things. It's something to add is if in this population of 250 bipolar patients that failed on lithium, these were the results of them going to Depakote versus Tegretol versus an atypical. That would be very useful.
It sure would be. And actually, there's a couple of studies before they stopped doing these clinical trials that were done both in kids and adults. They gave them the combination of lithium and valproate together, got them well, and then randomized them to either monotherapy, either lithium monotherapy or valproate. And 2/3 of the people relapsed on those monotherapies. And then when they put them back on the combination, they did better again and they got well again. So sometimes these combinations work better, and sometimes you really need complex combination therapy to get people well, because we're not just looking for our patients improved a little bit, but we're trying to get them all better. And that is a tough deal.
Yeah, absolutely. I just learned in the last month the Latin phrase restitio ad integrum related to lithium's use, the idea that for some super responders, they can have restoration to the original condition and essentially live a life free of the symptoms of major mood disturbances interrupting their lives frequently. So to me, lithium is, like I said earlier, it's the most effective drug that I have used in my practice. And it is so extremely safe in low doses. And I would say as safe as other medications I use in moderate to high doses, especially if you do your routine lab monitoring and monitor for clinical, side effects. I asked Janis Rybakowski about the effectiveness of lower doses, and he wasn't able to give me a whole lot of feedback. Another recent guest, Nasir Gami, he recommends titrating lithium to clinical efficacy, which I've had good results with. And admittedly, I probably also underdosed some of my patients initially on lithium. But I noticed in your new news about lithium paper, you put therapeutic level in quotation marks, indicating to me that you believe many effects of lithium you may be able to get those at less than what we consider the therapeutic dose. Can you give us some more historical background on where that therapeutic dose of lithium came from? As my understanding, it was just primarily determined based on avoiding a toxic dose or level.
Yeah, some of that's the case. There's some data by Willem Nolan in Europe that suggests that if you get into the therapeutic range of 0.6 to 1.1, you're going to do better. How low can you go is still an open question. So I actually give lithium at any dose that people are willing to take and tolerate. If they have a lot of tremor, I lower it further so they can take it. But there's data that 0.6 tends to be a good target. If you do 0.6 to 0.8, you're going to get fewer side effects long term. So lithium can be this great drug and restore you to, good health. And when I was at the NIMH, I saw all these patients and they let us keep the patients in the hospital until we got them better. So I wrote a book with illustrations of the mood chart of patients who got better. And it's called Bipolar, a case book for bipolar illness for patients and clinicians. and every chapter has a patient in it getting better on something. And some patients get better on lithium, like you're saying, alone, but some patients can get better on very complicated regimens. So that's my goal, is to get patients as well as they can be, hopefully better, and return to good functioning. And if it takes more than one medicine, that's what we need to do.
So Rif El Malik, he was one of the best influences that I had in my residency training. And, there are multiple theories, or maybe even, I mean, certainly multiple actions of lithium. He talks a lot about how lithium essentially tricks the neurons or disease neurons that have accumulated excess sodium inside of the nucleus of the cell, that nucleus is tricked and it takes in lithium preferentially, and the cell doesn't recognize the difference between a lithium or a sodium. However, in terms of the export pumps, they are more specific to sodium. So he talks about lithium getting trapped in the nucleus of those more diseased neurons, and by disease, the neurons that have accumulated excess sodium. That explanation to me lends the question of, can low doses of lithium over long periods of time have a cumulative effect like we see in some of these other newer areas of research, where the dementia risk probably builds over the course of at least a couple of years, along with other, anti-herpes effect, antiviral effects in general, a little bit of a boosted immune system and a less overreactive immune system, kind of keeping it in the guardrails. What do you know about low doses of lithium over long periods of time?
Yeah, there's actually a fair bit of data about that for lithium in the water people drink. You can measure minute levels, and they're about 1,000 times lower than clinical. But there's 6 to 10 studies that indicate that there's more lithium in the water, the lower the suicide rate is. And some of those studies are very well controlled. So that goes to your issue of, is there something about these minute doses of lithium over the long term that are doing something different? We don't know. So we don't know how lithium works. My take is that lithium works on so many different systems. Maybe that's why it works so well. Tons of different things, the sodium story, this story, that story, the inflammation story. So lithium is the second oldest substance in the universe. Right after the Big Bang, lithium was created. And so lithium, sodium, those kinds of things, we don't know all the details about how they're working, but what we do know is they can be highly effective.
So I got a couple other questions. They're more about Robert or Bob, the human being, less about you as a professional. I'm just curious, first, kind of where were you born and raised?
Born in New Haven, I used to ridicule the guys who went to Yale. You can't get a girl, get a Yaley. But then I turned out to be a Yaley. I went there, went home infrequently, had a great education there. And then, as you said, went to Penn. And I'm an East Coast person. I've been in Washington about 50 years now.
Okay. Growing up, what did you want to be when you grew up, and what kind of work did your parents do?
Yeah, I always wanted to be a doc. When some kid who was obviously pretty sick came to the front door, I said, let's see if we can think about doing things for this kind of a kid with some kind of medical care. My dad was a court stenographer turned labor arbitrator at age 50. He changed his job, and my mom was a school psychologist. So no direct medical people in the family.
Okay. When you get tired of talking about psychiatry or mental health or professional things, what do you do to unwind?
Play a little golf, not enough. Walk my dog, not enough. Read some books, not enough. those kinds of things.
Have you ever had a hole in one?
Yeah, I did once. And it was sort of bogus because I hit the first shot and it went sideways and backwards and a little over my head. So I said, I need a mulligan. And the mulligan was the hole in one, so it's not really official.
So you made a really cool par.
I don't like that. On my second shot.
That happened to somebody I was playing with one time, and we always tell him, "You made that really cool par that one time. It was fun to watch."
Oh my God. You say that to me and I'll have a convulsion.
I love playing golf. It is one of the most challenging and rewarding things that I've ever taken up as a hobby. So, and I've resisted it for a long, long time.
Yeah, it's a great thing to do as long as you don't take it too seriously. As I get older and older, I hit it shorter and shorter. And if I hit a few good shots, I appreciate it.
Yep. Yep. Absolutely. Who was or were the most influential persons or people in your personal life that more impacted, I guess, your philosophical approach in life?
Yeah, well, pretty clearly, my dad, who said always do things right and well, and he worked real hard. And my mom always drove me to get more education. Those two people were the key ones, I think.
Okay. Any professional major influences kind of early in your career?
Oh, yeah. Fred Goodwin was my main mentor and got me onto this longitudinal stuff. He says, okay, cute response is good, but what's the long-term response? And he was very influential. I would write a paper and edit it 6 or 8 times, give it to him, and he would correct it 6 or 8 times more. And William Bunny, Biff Bunny, was also key in that regard, a great mentor and supporter of my work. So those two were the biggest ones. Jan Fawcett never interacted with me directly, but he was my sort of pharmacological hero. He always did things that other people didn't do.
Yeah, that's one of my favorite things about doing this podcast. I mean, I do it for a reason because I, in my training, recognize that there are major problems in our field, and I want to be able to have an outlet for that and be able to help people understand that, the answer is not to turn away from psychiatry, but the answer is not also to take a medication for every mental health symptom that you have. And I love that piece that you mentioned about your mentor emphasizing the importance of a long-term response, because I just feel like we've devolved in our society to being hell-bent on treating symptoms and not actually modifying the disease in the long term, or even making the disease worse in the long term.
Yeah. With your favorite lithium, there's data from Finland that after a first hospital for unipolar depression, they looked at people 7 years later, and the people on lithium actually had fewer relapses than on antidepressants or atypical. So lithium, even for unipolar, is pretty interesting.
And yet it's not FDA approved, which is crazy to me. But I do think if I can reassure my patient enough to stick with it, that over a longer period of time, I've seen most people having a beneficial response. And again, because it's got all these different mechanisms of action, it may not be that they're responding to in terms of their mood, but they may be having a response in decreasing inflammation. Their body may feel better. They may be getting sick a little bit less often, and those might be enough to create a holistic situation where they don't feel as much of that depression.
Yeah, these things kind of multiply on themselves and can, sometimes really fit together nicely. Yeah.
I should ask you, do you have any disclosures that are relevant to our conversation today?
No, the one company that I've given some talks to or about but not recently, not in the last year, is Synovian, the guys who make Latuda, which I think is a very good drug. That's the main one. I used to talk for a number of companies, but not anymore.
Yeah. Well, I appreciate your time. You've been very generous with it, and you've been generous with information. So I appreciate you a lot. And honestly, I appreciate you for putting that new news about lithium, because it's really helped me add credence as a young psychiatrist to give to my patients and say, this is not just me making these statements. This is a body of evidence and literature and other much more well-respected psychiatrists with national and international clout that are saying this. So I thank you very much for that. And
Yeah, the other thing before we go is I thank you for the invitation. I learned a lot from you too. And the question is, when you make this film or whatever you do, put some slides on it, is that going to be available to me and others?
yes, absolutely.
Okay, well, appreciate it. Thanks very much for the invite. Take care.
Absolutely.
Okay, again, keep up all the good work.
All right. Thank you so much. Have a good day.
Take care. Bye.
Thanks again for watching and or listening. If you're passionate about the subjects that I discuss on the channel, do me a favor and like, comment, subscribe, do whatever you can to make your voice heard, that these are problems that must be addressed in our society. If you have any questions, comments, or concerns, I want to hear them. Feel free to reach out on social media or email us at renegadepsych@gmail.com. And if you'd like to be a guest of the show, or you have a connection to somebody that you think would be a good guest, let us know. Thanks again for listening.
Disclaimer. This podcast is for informational purposes only. The information provided in this podcast and related materials are meant only to educate. This information is not intended as a substitute for professional medical advice. While I am a medical doctor and many of my guests have extensive medical training and experience, nothing stated in this podcast nor materials related to this podcast, including recommended websites, texts, graphics, images, or any other materials, should be treated as a substitute for professional, medical, or psychological advice, diagnosis, or treatment. All listeners should consult with a medical professional, licensed mental health provider, or other healthcare provider if seeking medical advice, diagnosis, or treatment.